Oh, it says live. Hi, this is Dr. Linda Gray. I'm at Duke Medical Center, and I'm here to talk to you about cerebral spinal fluid leaks originating from the spine. This is Meet the Expert this week, which is CSF Leak Week, and I'm super excited to be here with everyone, and I'm looking forward to your questions. Ultimately, you're going to put your questions into the boxes down below. Okay. Okay, I guess it says people are watching. That's good. I got it right. I just want to tell you, at Duke here, I am joined by 3 other super physicians, Peter Krantz, Tim Amrine, and Mike Malinzak, who without those guys, we could not possibly make this service run. And we have such an awesome team of support staff. Hope Went, who is actually going to be here today, who's going to be reading out the questions. Hope, do you want to introduce yourself?
I'll say hello.
This is Hope, and she's going to be helping me today. So she's going to be reading out the questions to me. Also, we have Amy Harward, who does all of our scheduling. I'm sure some of you know her. She is a great support. And then there is also Lisa Hardister, who helps us, and Charles, who helps us with answering all of our questions, Charles Mandolin. And then there is Robin Yurchuk, who helps us with all of our administration. So I am ready to take your questions if everybody is ready to submit some questions. I can tell you that I got involved in this in 2006. So wow, that was 13 years ago. And since that time, I have just become embedded in this, and taking care of patients with cerebral spinal fluid leaks has been one of the most rewarding things I have actually committed myself to. So I would love to answer any questions that you might have at this point. Hope, do we have some questions?
Yes, we have some questions. What is the difference? Can you explain the difference between a targeted patch and a non-targeted patch?
Okay. The differences between a targeted and a non-targeted patch. A lot of times a non-targeted patch is applied in the lumbar spine. And it's when you really don't necessarily see something, or you want to try and figure out whether a patient actually has a CSF leak and has low intracranial hypotension, despite the fact that the MR imaging of the brain might be normal. You don't see a leak on myelography, and yet the patient is symptomatic. And so what you will do is apply a non-targeted patch, which is usually epidural in location. It could be at the thoracolumbar spine or in the lumbar spine. And it will give you some indication as to whether the patient actually has a CSF leak or not, because hopefully if they do, they will respond positively to the patch and they'll get better. And so then you might have an indication that that's the problem. A targeted patch, we do those when we A, can see the leak, or B, we think we have a patient with a potential site of leak, but we're not positive, and then we will target that exact site. So let me give you an example. Sometimes I might see a cyst that looks irregular, but I don't really see active leaking. Then I might actually target that cyst to see if it actually helps the patient get better. Or I might do the same thing with a calcified disc in the thoracic spine. When the patient seems to be symptomatic, they may or may not have MR imaging findings, and I will target that and see if that doesn't improve the patient's symptoms. So that's really the difference between targeted and non-targeted, is location, and whether you're targeting it to something where you think the patient actually has a leak, or if you suspect that might be the site of a leak spot. Okay.
Here's another question from Sarah. What is the link between perineural cysts and a CSF leak?
Well, okay, so perineural cysts, one of the ways that Peter Krantz likes to describe this is that lots of people have cysts, but they're kind of like moles. Lots of people have moles. They don't all turn into melanomas. So lots of people have cysts, but they don't necessarily they are not necessarily leaking. So you want to see secondary signs that might suggest a leak, like a halo around the cyst or some irregularity, or you might look for a CSF fistula that might be originating from that cyst. So you'll look for other secondary signs that might indicate that that cyst is a problem. And so they may or may not be the cause of the problem. A lot of times, sometimes you can have a arachnoid that can actually herniate through a cyst, and that can be the site of a leak. So diverticular can absolutely cause a leak, but they don't necessarily always cause a leak. So you have to look.
Okay, this question is from Lily. What is the gold standard for diagnostic procedures? And does that change depending on if the leak is spontaneous or iatrogenic?
Okay, so what I would say is the diagnostic study of choice for detecting a leak is to do a really thin sliced myelogram that is done under CT guidance, CT fluoroscopic guidance. Way back in the beginning, I did myelograms under fluoroscopy, and then took the patient on a gurney and then did a CT scan on the patient after they'd already been like a half hour after putting the contrast in. And that was too long, because if you have an active leak, you have to get that information right away, which is why we converted to doing, really, unless we're doing dynamic studies, we do our myelograms on the CT scanner table to start with. And we may do them dynamically on the CT scanner table, or we may do them just kind of routinely on the CT scanner table. Then after you do the myelogram, you need to have incredibly thin slices, which I didn't really realize in the beginning, but they have to be 0.625 or 0.5 millimeter thick slices, so that you can see some of the small details that you're actually looking for. Did that answer the question, I hope?
I think so.
Okay. Yeah. So CT myelography is going to be the study of choice. If it's a really super fast leak, you may have to do something more dynamic. Out at Cedars-Sinai, they'll do digital subtraction myelos with the patient under general anesthesia. We don't typically do that, but we will do dynamic myelography in our fluoroscopy suite, and we can do digital subtraction there, or we can do it under CT guidance. Okay.
This is from Donna. Can you pick up a leak when a patient's not having symptoms at that time, like if you're doing the myelogram?
Can you pick up a leak? This is from Donna. Donna, can you pick up a leak if...
Like if you do a myelogram, but the patient's not symptomatic at that moment,
but the patient's not
see the leak?
You can, yes. I mean, it doesn't really require that you necessarily be symptomatic at the time when you're doing the myelogram. A lot of times we'll still be able to pick up a site of leak. I've had patients who were absolutely not symptomatic, but I could pick up the site of leak. So you don't have to be symptomatic at that time when we do the myelogram. I love it when people come to me with their headaches, because I like to add and take away fluid in order to see sometimes if I'm not sure whether the patient has a leak. I like to add or take away fluid and see if actually CSF hypovolemia is their problem or not. Okay.
This is a good question from Jody.
This is from Jody.
What can you say about patients with venous fistula, CSF to venous fistulas, and blood patches? Do blood patches fail more often, and do these patients require surgery? Okay.
So in regards to CSF leaks, can you patch these patients, or do they require surgery? And you know what we have found is that occasionally, actually, I've had patients with what look like fistulas, and we have patched them and they've done well. In general, those patients are going to wind up having to have some kind of surgery. So I will patch them twice, but the second time they come back to see me, I'm going to have them see a surgeon, because if it recurs again, I'm just not going to repeat the patches. I mean, there's just no point. So I would say, in general, yes, they are going to require surgery. Yeah. Another question?
Okay. I'm going to kind of paraphrase. This is from Marta.
She's
asking about people with connective tissue disorders and leaks, and do they tend to re-leak And is there any connection between the two?
Okay, is there a connection between leaking and connective tissue disorders? There are lots of patients who have some spectrum of Ehlers-Danlos. And I would say that those patients don't necessarily have to have a leak, but it might predispose you to having leaks. Some of the patients with Ehlers-Danlos are actually hyperreflexive. And those are the patients who are like great gymnasts and great athletes sometimes will have some kind of connective tissue disorder. And it is, they can definitely have leaks, but you don't necessarily have to have a leak. But in somebody who does have a history of some kind of connective tissue disorder, we certainly have a higher index of suspicion and higher sensitivity to those patients. Patients with Marfan's, that is a very challenging connective tissue disorder. Those patients have lots of symptoms. They can have cardiac abnormalities, and they can have some serious cerebrospinal fluid leaks that originate from big extradural cysts and pseudomeningoceles that can occur particularly in the sacrum. So we're super aware of that, and that can definitely predispose those patients in particular to having a CSF leak. Okay.
Can you tell us a little bit about rebound high pressure and what that is?
Rebound high pressure, what is that, and who's that coming from?
That was kind of a paraphrase from a couple different ones.
A couple of people asked about rebound high pressure. Yeah, it's interesting. Way back in the beginning, when I first started taking care of patients, I would patch them. They had a definite leak, and then they'd come back with a different kind of headache, which I didn't really understand in the very beginning. And then we would check their pressures, and their pressures were a lot higher. We found out that if we took off fluid, they would do a lot better. And so it always was, we were always trying to get to anybody's sweet spot in terms of pressure. And that's when we started adding in Diamox and other kinds of diuretics in order to help those patients post-patch with their rebound high pressure. So rebound high pressure, I think, is super common. I see it particularly in patients who have active leaks, in patients who have CSF fistulas, in patients who have discs that actually are causing penetrating leaks. So yeah, I see them in those particular instances, and it can last for a while. Then there's the high pressure problem where patients maybe present to us with a low pressure problem, but their real problem is high pressure, in which case we have to actually treat the high pressure. So some people with high pressure will blow out. We see them when they blow out, and then we will have to actually treat the patch and then treat the rebound high pressure or the high pressure that may be actually their original problem to begin with. So rebound high pressure is something that happens definitely after patching for cerebrospinal fluid leaks, and we're always on the lookout for whether patients don't actually have high pressure to begin with, and then maybe they're going to have to be treated for a while for high pressure. Okay. Next question.
Okay. This one was from Michelle. She was asking about when you get your LP done and your opening pressure is low, would you assume that someone would have a leak, and should you continue imaging based on an opening pressure?
Okay, so if somebody has a low opening pressure, and let's presume that the pressure is taken accurately, because some reasons for low pressure is that the needle is not exactly in the center of the canal. It could be sidewalled or something like that. Sometimes patients will come to us with purportedly a low opening pressure that was obtained maybe at bedside or in fluoroscopy or something like that, and actually, their pressure will be 0 or 3 or low below 10, and when we see them, their pressure is like 17, 18, 19. So occasionally what it turns out to be low pressure in some instances is just the needle being sidewalled and not exactly in the center of the canal. So we always keep that in mind. We like to get our own pressures, and when pressures are obtained, they should be in the lateral decubitus position, kind of relaxed and very comfortable, and then we get the pressure, and that's the most accurate pressure. Now, if the pressure is low, for sure, we're going to start looking for a cerebral spinal fluid leak, even if the pressure is normal or high. If the patient is symptomatic, we're just going to go and look for it. Because the highest pressure that I've seen actually was a pressure of 31.5 in a patient who actually had an active spinal fluid leak. So you cannot count on just the number alone to tell you whether the patient that you're interfacing with actually has a high or a low pressure problem. So you have to get the information and look for the leak. Yeah.
Okay, this is coming from Ronnie. Do you ever see evidence of a venous fistula or ventral dural defect on full spine MRI with contrast? So can you see them on
Okay, so can you see, this is from Ronnie, and can you see a cerebral spinal fluid venous fistula on MRI? That is super uncommon to be able to see that, because these are really, you have to see them dynamically. You would probably have to have intrathecal contrast on that MR myelogram if you were going to have a chance to see it at all. You will not see it just on the MR scan alone. There was one time that Tim and I thought that we saw a vein going off, and we were probably right. That probably was, and it was an MR scan. But I don't think that you can count on an MR scan to pick up a CSF venofistula. That's my thought about that. Yeah. Yeah. Okay. So let me, if everyone's just, came in late at all, this is Meet the Expert. I'm Dr. Linda Gray. I'm at Duke Medical Center, and I'm joined here by Hope, who is reading out questions to us. We have a whole team of people and a team of physicians who really take care of patients with this problem. So this is for Spinal CSF Leak Foundation, and this is Meet the Expert. So anyway, keep your questions coming. Look forward to hearing them.
Okay, and this one's from Linda. How long does rebound high pressure last?
Okay.
And can you tell us about the longest time or the longest patient you've had with the rebound high pressure?
Okay. So this is from Linda, and the question is about rebound high pressure and how long can you expect it to last? Well, I know that I have some patients who have had rebound high pressure actually for years. And why that is, I don't entirely understand, but yes, that's not typical. That's pretty atypical. Sometimes rebound high pressure only lasts a few days, but it can last weeks to months. And I'm not really positive that I can actually tell you who is going to have that and who's not going to have that. So it's hard for me to know for sure. But yeah, it's super variable. And then of course you've got the patients who are maybe high pressure patients to begin with, who present with a leak, and then you're going to be treating those people with high pressure or for high pressure, for the duration until we fix the high pressure problem.
Okay, and this will kind of lean into Carolina's question. How serious is rebound high pressure? Carolina,
her question is, how serious is rebound high pressure? Well, if you look under, on the web, under intracranial hypertension, if you're not at your sweet spot in terms of pressure, high pressure can be just as serious as low pressure. You can have a wide constellation of problems. You can have blurry vision, double vision, all the same things that you get with low pressure you can get with high pressure. So high pressure is equally problematic. Now, for the short term, with rebound high pressure, it's probably not a big issue. I can tell you that I had one patient who actually got serious rebound high pressure after a patch. Her pressure went over 55 centimeters of water, so it came out the top of the tube of the manometer. And we had her checked, her orbits checked, we looked for papilledema, and her optic nerves were totally normal despite the fact that she had incredibly high rebound high pressure. So, you want to keep an eye on patients like that. You certainly want to treat them appropriately, but it may not necessarily in the short term be terribly serious. But you do want to keep a handle on it because it's pretty miserable sometimes. Okay.
Okay, one more about rebound high pressure. What are some classic symptoms of rebound high pressure?
Okay, so rebound high pressure is going to be kind of the opposite of what you get with low pressure. So most of those headaches, rebound high pressure, are going to be on the top of the head or the forehead or the face or the eyes, whereas intracranial hypotension tends to be more at the back of the head and neck. So it'll be kind of opposite from the headaches that you have typically had, and you'll feel better sitting up or standing up. Interestingly, I've had some people with rebound high pressure feel worse when they sit. They feel better when they stand or lie down, but when they sit, they feel worse. And I think some of that is because the abdominal contents actually put pressure on the venous return from the head, and they can increase the head pressure as a consequence. So anyway, interestingly, that rebound high pressure can present a little bit worse with sitting, better with lying down, or just standing up as well. But it'll be opposite of what you would normally have. Okay, what
this
else?
One's coming from Caitlin.
This is from Caitlin.
What overlap relationship have you seen between POTS and CSF leaks?
Oh boy. POTS and CSF leaks, what is the overlap? You know, that is something that really needs to be dissected out better. Because I think there's a tremendous amount of overlap. I have seen a lot of patients who had positional headaches and POTS-like symptoms with, and even tested positive for POTS. So positional blood pressure changes and things like that. The thing about that is that sometimes when you treat the CSF leak, the POTS symptoms go away. So I think sometimes you have to treat POTS patients as if they might have a CSF leak. Maybe in those cases, you might try a non-targeted patch if you don't see something, see if it makes the patient better or not, and then test them for POTS after you rectify whatever you think might be a CSF leak. So there's a tremendous amount of overlap, and I don't think we have the answer yet to how we determine whether patients just have a CSF leak or just have POTS. Okay.
Okay. Let's see. Can you list, I know we talked about some symptoms for rebound high pressure. What are like the classic hallmark symptoms for low pressure for a CSF leak?
Okay. Classic symptoms for low pressure is that it's going to be a headache that is going to get worse when you're upright, but that can be minutes to hours. So sometimes people will get late in the day kinds of headaches with a CSF leak, but sometimes they'll have only minutes of upright time. Excuse me. So that would be classic. But they can have other things too, right? They can have nausea, vomiting, double vision, blurry vision, tinnitus, disequilibrium. They can have dizziness, and cognitive problems are super common. So they may have memory problems. We've had patients with dementia who actually didn't have headaches at all, but just presented with kind of dementia symptoms. And that was due to a CSF leak. So I think one of the things that is underestimated is the cognitive issues that can actually present in patients with intracranial hypotension and CSF leaks. So there are a host of things. A lot of the cranial nerves can be affected. So I've had patients with swallowing problems, speaking problems, slurred speech. All of those things can happen with cerebrospinal fluid leak. So anything that any of the nerves that come out of the head can be affected by cerebrospinal fluid pressure problems. So it's always important when you have multiple cranial neuropathies to think about a potential cerebrospinal fluid leak. Okay.
This one's from Dina. Can we tell whether a leak is fast or slow before invasive imaging?
Okay, so, wow. I guess sometimes it's possible that intermittent leaks tend to maybe present, this is hypothesis, but I'm just going to guess, that maybe intermittent leaks or slower leaks, you might have more upright time and the headaches might present later in the day. That's what you might expect, but that's not always going to be the case, because I've seen people with tremendous brain downward herniation, sagging, and they actually, you just don't see a leak. So they may be more chronic leaks in that case. So I don't think that we can always tell whether it's going to be a fast or slow leak. I've had some patients with really fast leaks and they have no upright time. But I've had some patients with fast leaks, and because their overall cerebral spinal fluid pressure is higher, they actually have more upright time. So I think there's probably a balance between the speed of the leak and the amount of pressure that you're able to maintain. Okay?
This question is, explain the difference between using CT fluoro versus fluoro guidance.
Okay. The difference between CT fluoro and fluoro guidance is the question. Fluoroscopic guidance is like a two-dimensional image. So it would be like if you took a patient and you compressed them and you saw both sides of them on an image. So it's like looking at a picture, which is a two-dimensional image. A three-dimensional image is what you get with CT fluoroscopy, in which case you get to see like a volume of the patient as opposed to just looking at a two-dimensional image. And having CT fluoroscopy gives you the ability to do procedures that are that require high accuracy. So some of the things that we do in terms of patching and stuff we would never be able to do under fluoroscopic guidance. You need to have 3D imaging capabilities. Now with CT fluoroscopy, you are right next to the patient as you are with fluoroscopy. And so you are standing right next to the patient doing the procedure, but your accuracy has got something like 500 micron accuracy with CT fluoroscopy. Okay, another question?
So, yes, this is from Patty. And if you have brain sag, once the leak is repaired, does the sag go away? And I'll further that question by any of the signs of intracranial hypotension.
Sure. This is from Patty. Do signs of intracranial hypotension go away after you patch the hole? And the wonderful thing about it is yes. So when we've had patients who have had terrible brain sag, and dural enhancement, and they've had symptoms for, several years, and thankfully those brains actually will move back up into the head when you treat those patients. I always like to follow up the patients who have had really terrible brain sag with follow-up imaging, because I like to just be sure that we've treated the patient is better, and the brain looks better. So yes, they will get better. Okay.
This kind of is coming off of a question for Kimberly. If someone's had a leak and it's been repaired, can they develop another leak in a different location?
Okay. This is from Kimberly. If you treat a leak, can somebody develop a leak in a different location? We haven't really. Okay. The situation where that might come up is if you have several calcified discs in the thoracic spine. It is entirely, and superimpose on that maybe a connective tissue disorder as well. Then it's possible that you'd solve one problem and you could get another problem. So yes, in that particular situation, it could happen. I'm not really aware of it. I guess it's probably possible too with diverticuli and herniations of arachnoid through different nerve root diverticula. It could probably happen in that situation as well. I would say in general, but those two situations with diverticuli and with the disc herniations, it's entirely possible. I have not really seen that happen yet with CSF fistulas so much, now that we're identifying them well, but we don't really know what caused CSF fistulas. It's possible that they could have a recurrence as well. So I think we just don't know the whole story on CSF fistulas yet. Okay.
This one's coming from Nicole.
Is
CT imaging more accurate than MRI for detecting leaks?
Is CT more accurate for detecting leaks than MRI? And I'm going to just give that a resounding yes. I think you have to do a CT myelogram in order to see the leak, so you can't just do a CT scan without doing a myelogram. And then with MR scans, also just doing an MR scan without any contrast in the thecal sac There's some people who feel like MR with contrast is more sensitive. We have not really found that to be the case. We found that CT myelography, because of the higher resolution imaging, is better. Now, one of the things that people might say about MR myelography is that the contrast to noise is better and that it might be more obvious, but we just have not found that to be the case either. So I think in general that CT myelography is going to be more sensitive and specific for finding leaks than MR scanning.
Okay, this one's from Pierre. Can you explain what DSM is?
Okay, Pierre, it asks, what is DSM? Digital subtraction myelography. So what that is you actually, while the contrast is going into the spinal canal, you do it, you get a subtracted image with the contrast on board so that you get rid of all of the overlying tissues like the bones and other soft tissue structures. So all that you have left is basically contrast on the image. So it's really a subtraction technique for taking off all the bones and soft tissues in order to just see the contrast that is in the thecal sac. So that's what it is. And you can do it dynamically, as they do out at Cedars-Sinai, where they tip the patients maybe head down. They suspend respiration, because one of the problems with digital subtraction is you have to have a very the image has to be exactly the same so that when you're subtracting the image that you actually get just the contrast on board and you don't have a lot of artifact, which can happen with digital subtraction. So that's the one thing that you have to be concerned about.
Okay. This one's from Libra. What is the best test for fistulas, and is it standard to look for these when looking for leaks?
Okay, and this is from
Libra.
Is it standard practice to look for CSF fistulas? So in our practice, it is super standard and I think everyone is looking for them now, because I think it was 2014 when the first paper came out about CSF fistulas, and since that time, all of us are looking for them. They can be tough to see. Sometimes you have to do provocative maneuvers in order to find them, like maybe put the patient in bilateral decubitus positions in order to see a fistula and see the vein draining out around the spine. So yes, I think everybody is really looking for the CSF fistulas. I think they've been really underappreciated. And we didn't know we needed to be looking for them until about 2014, and now everybody is seeing them. I think in the paper that Dr. Shivink wrote recently, I think their incidence of CSF fistulas was pretty low, but I bet you over time that we're going to see more of them as we know how to look for them. Okay, can you kind of explain a little bit with someone who has a known intracranial hypotension, they've had patches and they're not getting better? Do you do different imaging? So yes. In patients who are not getting better, who have intracranial hypotension, and in the setting where you know they have it, because their brains demonstrate sag and dural enhancement, and you're just not finding the leak, you can go on and do some extra things. You could put the patient in the hospital and put in a lumbar drain and increase the CSF pressure, and then do myelograms after that. And we used to do that in the past. We don't feel like we have to do that now. The other thing is look for things like discs where you don't see a leak adjacent to it, or really irregular cysts. And sometimes it's really super tough. We've had a couple of cases where actually we saw a leak on the third myelogram. So sometimes you just have to repeat the studies in order to try and find it. And sometimes if I can't find it, I'll send somebody out to Cedars-Sinai or Mayo Clinic and see if they can find it when I can't find it. So sometimes they're just really, unfortunately, challenging to find.
This question's from Jennifer. What's the difference between a CT Cisterna Graham and CT myelogram?
Okay, this is from Jennifer, and the question is, what is the difference between a CT Cisterna Graham and CT myelogram? So a CT Cisterna Graham actually looks for any kind of a leak at the base of skull. And that in general would include like the paranasal sinuses, base of skull where the cribriform plate is, or temporal bone and mastoid air cells. Typically, leaks at the base of skull are usually secondary to high pressure and not typically causing intracranial hypotension. That's in general, we'll probably find some cases where that's not true, but usually when you're looking for base of skull leaks, you're doing a CT Cisterna Graham. A CT myelogram, on the other hand, actually looks at the spinal axis. So everything from cervical spine to sacrum is what a CT myelogram looks at. Okay.
This question's from Jennifer.
Jennifer?
Are Tarlof cysts from a CSF leak or CSF issues?
Are Tarlof cysts from a CSF leak or CSF issues? Tarlof cysts, again, are one of those things that are super common, and they don't have to leak. I've seen a number of people who have had surgery on those with some pretty significant sequelae that are not entirely favorable. I don't think you can assume that Tarlof cysts usually occur in the sacrum, and they're very common. We see them a lot. What they represent, they're just cysts. I don't know why some people have more than others, but it is definitely the case. And I don't think that they necessarily have to leak either. So it may be cases where they leak, but most of the time we don't even think of them as causing CSF leaks in general. They have caused leaks when people have had iatrogenic things done, like had epidurals or nerve root blocks in the location of a cyst, in which case most of the time it just doesn't seem like those things should be operated on in general. I could be wrong sometimes about that, but that's in general. I don't think they need to be operated on. Okay.
This is from Natalie. How often does a blood patch cause nerve irritation, causing painful post-blood blood patch complications?
Okay, Natalie asks, how often post-patch do you get nerve root pain? And definitely that can happen. That's usually easily treated by doing just a nerve root block afterwards. I've had that happen several times. Actually, even after an epidural blood patch in the lower lumbar spine, it can cause pain. It's generally pretty easily treated with just doing a nerve root block with some steroid and some bupivacaine, and usually is pretty helpful, and usually can get rid of the pain. So hopefully somebody's been able to rectify that for you. Okay,
here's another question from Libra. Can you explain
Libra.
how nerve root sleeve cysts form? And are you born with them, or do they occur over time?
Okay. How do nerve root sleeve cysts form? They actually, some people with connective tissue disorders have those a lot more than other people. And it's interesting, but some people with intracranial hypertension tend to have very few nerve root diverticuli. So I think in general, you're probably born with them unless you have some kind of traumatic event. So I've seen some large extradural arachnoid cysts, which were likely the consequence of having had some kind of trauma. And in those cases, they weren't born with those, but they were actually a consequence of trauma. I would say in general, so you're going to see those more in people who have connective tissue disorders as opposed to those who don't. So I think in general, you're probably kind of born with them. Yes.
Okay, Justin asks, can we ask if an ultrasound picks up pooling? I'm guessing pooling of the CSF.
Justin asked if ultrasound shows pooling of CSF. Usually, in general, you can't see that with an ultrasound. And part of the reason for that is because the spine gets in the way and you don't always have a very good window into the location of where the pooling is. We don't typically use ultrasound to detect CSF leaks in that way. Maybe if it was a baby, or maybe if you were looking for it post-epidural catheter placement, maybe you could use that. But we typically don't use ultrasound in order to look for CSF leaks in the spine.
Can like brain sag cause damage if a leak's not repaired?
Okay, so the question is, can brain sag cause damage if a leak's not repaired? And the answer is yes. With brain sag, you get terrible cranial neuropathies. So as I said, every nerve that comes out of the head can cause problems. So you can have problems with swallowing, and if you don't correct the intracranial hypotension, then you can have problems with aspiration. And then you get aspiration pneumonia. The memory problems are not going to improve if you don't rectify the problem, and so you can have serious cognitive problems and dementia as a consequence. So yes, you need to rectify the intracranial hypotension and the brain sag in order to improve the patient.
Okay. This question's from Amy. Can you have a leak and not have brain sagging show up on an MRI?
Okay, so this is from Amy. Can you have a leak and a normal brain imaging study? And the answer to that is absolutely yes. I had a patient probably in 2018, summer of last year, who was actually rocking on her front porch in the mountains of North Carolina, and she developed a terrible headache. And she couldn't sit up, she could only lie down. Her brain was absolutely normal, and yet she had a big CSF leak caused by a calcified disc in the thoracic spine. So a normal MRI scan of the brain does not exclude a cerebrospinal fluid leak. Okay, how are we doing on...
We're probably going to only take about one or two more questions.
Okay, one or two more questions.
Okay, are there any studies that you can do for patients who have contrast allergies?
Okay, are there any studies you can do in patients who have contrast allergies? Well, first of all, you can treat contrast allergies pretty effectively, and most of the time we can treat them with a steroid dose pack that is started about 13 hours before they have the myelogram, and we can generally do that. If a patient has like anaphylactic reactions to iodinated contrast, we would probably do an MR myelogram. Most of the time, people who have an iodinated contrast reaction are not also going to have an MR contrast allergy, and so we will have an option of doing either MR myelography or CT myelography. But a lot of times we can treat patients with steroids ahead of time, and they will do just fine. Does that answer that question, do you think?
I think so, yeah.
Okay.
How about we do one more?
One more question.
This is from Julia.
What
are the main differences in your approach to diagnose and treat of leaks in patients with Ehlers-Danlos?
What are our differences in the way we treat patients with Ehlers-Danlos as compared to other patients? And you know what? We really treat everybody pretty much the same in that regard. So we'll just have a higher index of suspicion and maybe do lateral decubitus imaging in those patients. But in general, we're probably going to do lateral. If we're really suspicious for a leak, we're going to do lateral decubitus imaging and prone imaging to look for a CSF leak. So we're going to really treat everybody almost like they have a connective tissue disorder in general. Okay, so listen, thank you so much for joining us. Thank you so much to the Spinal CSF Leak Foundation for doing this Meet the Expert. Really enjoyed talking to all of you. Hope that I've answered your questions sufficiently and that I didn't talk too fast today. But anyway, look forward to doing this again. And hope all of you are doing well and are getting better out there. Okay, thanks so much.